Good afternoon. Welcome to Purview's February webinar entitled "Do Remote Second Opinions Open New Doors?" A couple of ground rules as we get started. There are more people joining us apparently as we're getting going. First of all, just note that the audience, all of your mics will be muted during the presentation. If you do have a question, please type it in the question bar that's in the sidebar to your screen. And we'll review those and try to get to as many of those as we can towards the end of the presentation. Other than that, please sit back and enjoy. And if you do have some questions, feel free to raise those to us in that chat box. So my name is Les Trackman. I am the CEO of Purview, and we're a company that's in the health tech business focused on enabling expert and remote opinions through technology. But more important than that, joining me today are a set of guests, including Claire Kelly, who is our Director of Product from Purview. With her today are the guests, Nikki DeLucia from Yale, Cole Manship from Memorial Sloan Kettering, and Dr. Peter Rasmussen from the Cleveland Clinic. What I'd like to do to get started is just have our guests do a brief introduction, and then we'll jump right into the content of the presentation for today. So Nikki, you want to start off, please?
Yeah, thanks, Les. So hello, everyone. Again, my name is Nikki DeLucia. I am currently the Director of Ambulatory Telehealth for Yale New Haven Health System and Yale Medicine. My background when it comes to remote second opinions actually started when I was the Program Development Manager at Yale Medicine. And again, it has now pivoted a little bit because I'm very much focused on how this interplays with telehealth in today's new world that we're in all around telehealth. So excited to talk to everyone about that today.
Thanks, Nikki. Cole, you want to be next, please?
Absolutely. Thanks, Les. Cole Manship. I work in the Strategy and Innovation Group at Memorial Sloan Kettering Cancer Center. In my role there, I oversee product strategy for a program called MSK Direct. So MSK Direct is an oncology health benefit solution where we expand access to Memorial Sloan Kettering's expertise in oncology to employers and their employees and dependents around the country. It's actually the largest program of its kind. We have about 150 employer partners in that program who collectively cover almost 5 million lives. Great.
Thanks, Cole. And Dr. Rasmussen, would you please introduce yourself?
Hey, good afternoon, everybody. Peter Rasmussen. As you can tell, I'm continuing to practice medicine at the Cleveland Clinic. I spend half my time doing neurosurgery. The other half of my time I've spent over the past 8 years heading up digital health for the Cleveland Clinic across the enterprise. And then 2 years ago, moved over to be Chief Clinical Officer for the Clinic by Cleveland Clinic, a spin-out company that's a joint venture between the Cleveland Clinic and Amwell. And we've been predominantly focused in the virtual second opinion space. It's a global program providing access to Cleveland Clinic expertise across the board. The Cleveland Clinic as a whole has been doing remote or virtual second opinions for about 18 to 20 years totally. We did revamp the program 2 to 3 years ago, brought it more into the modern age and fully digitalized it. I'm delighted to be here today.
Great. Well, thank you. I'm excited to have you all here and to hear from the horse's mouth, if you will, about what you're doing. Just to do some level setting to start out with, each of these programs is at a different stage of maturity. So you may get different answers based upon that to the questions that I raised. And as I said, if you have some additional questions, we'll be happy to try to deal with those as we get through the program. So let me start out by posing a general question to our panelists, and that's what is the real reason that you've started a virtual or remote second opinion program at your organization? So Nikki, do you want to start with that one?
Sure, happy to. So I think as I listen to my co-presenters, I would say that we at Yale are probably in our infancy compared to others, even though this is something that we've been working on for about 7 years now. Again, it started within our network development department, much like Cole's did in his area. And it really was a strategic decision for us to kind of move forward with having a remote second opinion program. A lot of it often comes from when we have new providers who come to Yale from other entities who are already doing second opinions. And again, just like all of us, our providers are world-class providers, and people know about them from not just across the country, but internationally. And so they want to be able to extend their programs and do outreach to people around the world. And so when they come, it's very important for us, again, even as a recruiting technique, to be able to have people come here to Yale and be able to offer a program like this. So again, it started as a strategic decision for us, but then also as we now collaborate, like I said, with my program in telehealth and also our international medicine program, it just really became a good fit to be able to offer this through all of those programs and see how they can work together on this strategic vision that we've kind of all set for ourselves. And again, just really kind of opening up those doors so that our providers have access to the patients and the patients have access to our providers is really what's most important to us.
Cool. You even use the open new doors words. That's great. How appropriate. Thanks, Nick. Cole, how about you? How did you guys get, or what's the purpose behind that at MSK?
Yeah, there are lots of reasons, why we were interested in remote second opinions. They expand our impact and influence outside of our traditional geographic area where we focus. It's a funnel to in-person care at Memorial Sloan Kettering. It increases the relevance of MSK Direct to national employers. But if I had to boil it down to one kind of fundamental reason why remote second opinions are a priority for us, it's to position Memorial Sloan Kettering to succeed in a future that's increasingly hybrid, increasingly digital and non-digital, and in a world that's going to be less constrained by geography. So if you look at every other industry besides healthcare, you look at retail, you look at banking, you look at insurance, those industries are dominated by a few national players that have deliver hybrid solutions, digital and non-digital. And I have every reason to think that the same will eventually be true of healthcare. And we're starting to see signals of that happening already. And offering a solution like remote second opinions allows us to start getting comfortable providing healthcare services in a non-traditional way that are nationally available and not being delivered in person.
Great, thanks, Cole. And Dr. Rasmussen, you're probably representing the most mature program of all of them, so I'm interested to hear your response to that as well.
Yeah, I think it's really pretty similar to what MSK and Yale are saying. This is really a strategic move for the Cleveland Clinic. We view ourselves as a global health system, a global health resource for patients around the world. And you can't be everywhere with physical bricks and mortar assets. So we view this as an excellent front door to our expertise for patients around the world to be able to get an opinion from the Cleveland Clinic. It's not uncommon, similar to Memorial Sloan Kettering, we've got obviously global expertise in cardiac care, and patients frequently may be frustrated with their local healthcare system or what options may be available to them. And, they wonder, hey, does the Cleveland Clinic have something to offer me for my cardiology or cardiac surgery needs? And this really gives them a fantastic way to access our experts without having to travel. And it's all really starts with the fact that electronic health records over the past decade or more have become increasingly digital. And it's very simple, relatively simple to ship images and medical records around the world. In the most part, a full set of medical records can be around a specific problem can be accumulated or assembled in a matter of days, sometimes within a matter of minutes, if we're all on the same common EHR backbone. And through image cloud sharing solutions, the images can come very, very rapidly. So all of these things together, strategic needs, access for patients, improving technology resources around the globe really make sense to put together a second opinion program.
Great, thank you. And Claire, you've done a lot of work with some other hospitals, including a bunch of children's hospitals. Do you have any thoughts on that about their motivations to get this stuff started?
Yeah, so just for everyone's background, I am a product person at Purview, but I'm kind of speaking for the larger group of clients that I work with, and typically they're healthcare providers, but everything that ranges from a specialty hospital to a subspecialist practice to a health network internationally. And I'm just here to kind of fill in color about the larger conversation that we're hearing, in addition to the experiences and insights of our great panelists here. And one thing, so much of what everyone has already said, including patients expecting this as an avenue for receiving care, because they receive it in every other industry, as Cole pointed out, and also especially from institutions that have a strong brand presence, as all of these do. But a lot of these hospitals work really hard on facilitating really strong brands and getting their expertise of their physicians out there. And so to not utilize that to bring patients in is you're losing a network that you would be able to create. A lot of the hospitals that I speak to, especially children's hospitals, say that a lot. But additionally, a lot of these institutions that went into, especially the last couple of years, without a program for remote consults, look at institutions that had something set up, especially going into this pandemic, and already had these channels for doing some amount of remote care, at least, said to themselves, wow, I wish we had something like this for such an unprecedented situation, and kind of had to scramble to figure out how to catch up to institutions that were sort of leading this change in the marketplace. And if some of you here are having similar thoughts, don't worry, that's the majority of healthcare institutions from what we're hearing. You're in very good company with a lot of really great institutions, but a lot of it is making sure that you can keep up with the expectations set by institutions that are leading these sort of healthcare programs.
Great, thanks, Claire. So what we're finding is that there's obviously great rationale for setting these up, but it's not that easy that we found. So if you wouldn't mind, panelists, and I'm going to reverse the order and ask Dr. Rasmussen to go first. Is there a single challenge that was the biggest challenge for you as you implemented this program?
No, there's actually not really one single challenge around this. It's really multiple challenges. Because clearly there are technology barriers that are in place. There are marketing barriers in place, questions about licensure and operation capabilities, things that are different domestically and internationally. And there are a fair number of things that all have to happen, including, how do you engage the physicians in delivering, care in a relatively different and atypical way. And, I guess I'll focus on that issue to answer this question, and can chime in on other things if wanted. But historically, over the past 18 years, there has been a little bit of trouble engaging Cleveland Clinic physicians in remote second opinions. The way our institution works, we're on salary as physicians. We have a very clear defined set of work that we do. You see X number of patients in the office, and you do your surgery or your procedures if that's part of the scope of your practice. And then here you're asking physicians to add on these second opinions that are frequently going to be done at the patient's convenience, as opposed to at the physician's convenience. So engaging the physicians was somewhat of a challenge. And the solution that we really came to was making sure that we were bringing only the patients to the physicians that met their subspecialty niched expertise. So as an example, I may be a neurosurgeon, but I only do cerebrovascular disease. We would not bring a brain tumor to a physician like myself. It would be brain aneurysm or AVM. And then even in that regard, physicians everywhere, providers everywhere tend to be incredibly busy. And beyond that, to deliver an expedited premium product like we're trying to offer to patients around the world, it does require timely delivery of the opinion. And essentially, we are paying moonlighting rates to physicians to buy expedited access to their time and their schedule. So those are really the two solutions that we brought in place to get physician engagement. And all that being said, it's still not the right thing for every physician. Gratefully, we have over 3,500 subspecialty physicians that we can draw upon for our second opinion program, because there are going to be 10 to 15 or 20% of physicians who just aren't interested in doing this kind of work. Maybe they've got a research focus and they've got grants due, or they've got things going on in their personal life where they don't want to take on extra work, etc. So it really does require some creative thinking about engaging your physician workforce in this.
Great, really important issue we're seeing in the marketplace as well, something that everybody needs to consider. Cole, any specific one hurdle that you found?
If I had to narrow it down to one thing, everything Dr. Rasmussen said really resonated with me. Physician adoption and buy-in has been the greatest challenge. Now, it's easy to think of doctors as this homogenous group. We've always found that there are doctors who are very enthusiastic about this on one end of the spectrum, and doctors who have zero interest in doing this on the other end of the spectrum. And navigating that has been a little bit tricky. For those who don't know, Memorial Sloan Kettering is the oldest and largest private cancer center in the country. So we have a very long and successful history of providing expert cancer care in person to individuals in the New York metropolitan area. And remote second opinions are very different from that. They're available nationally. We're not actually providing care in remote second opinions, and the doctors aren't seeing these patients face to face. And because it's so different, it can be scary and difficult to prioritize, particularly when we've been so successful without them. A lot of the strategies that Dr. Rasmussen discussed, we're doing the same thing to kind of overcome those barriers. The one piece of advice I would give is find, if you're launching a program, is find those doctors who are enthusiastic about these types of programs, who do see the value, and start there, and then gradually expand and build.
And you also pay an equivalent of a moonlighting rate to physicians for doing these?
We did for several years. We've recently transitioned to the point where this is fully integrated into physicians' productivity. And so there's no longer a need to pay the additional moonlighting compensation.
Interesting. Nikki, what have you seen as the biggest hurdle?
So everything everyone said, again, we have dealt with as well. I think just to put a different spin on it, and again, being that we are a little bit younger in the maturity of our program, I would say probably our biggest obstacle is scaling the program, right, amongst all of your other competing priorities. So, and then again, when you add in a pandemic on top of all that work that you did, as we all know, many things got put to the side when the pandemic hit because we had to focus on other areas. So, I mean, I think, again, when you take something from a strategic vision, right, and sitting within your strategy department and all the work that you do there, and then being able to take that program and then hand it off to your operations and having all of those workflows in place, like we were saying, whether it be the providers and how they do it and how they get paid for it, how you interact with your marketing, because that really is a big part of your remote second opinion program. Dealing with your legal department and ensuring that you have everything in place accurately when it comes to licensure, when it comes to malpractice coverage, how you represent those things, how your providers are documenting. All of those things need to carefully be ticked and tied out, as well as, again, whether you decide to totally do this in-house within your own IT platforms, within your own EMR, or whether you decide to partner with a vendor who may help you with all of those things, from the collection of the medical records, the translation of the medical records if you're doing it internationally. All of those things are very important pieces of a program that without it, they don't work. And there's so many spinning wheels that you really need to make sure that you are growing it and growing it accurately. So I think finding that best fit and then being able to mature it into a program that you can kind of pass along and it just chugs along on that operational part of it is really kind of, you know, where we are today. And I think really where it takes a good vision and always going back to that strategic vision and understanding why you're doing this and being able to make sure that your leadership always continues to support it, to make sure they understand why this is an important avenue to focus on.
Great. And Claire, I know you've run into a zillion issues. Could you just briefly hit on one or two issues that are beyond the ones that the panelists have already identified?
Sure. Yeah. So to cheat on that a little bit and touch on one that everyone has sort of mentioned, picking where to start is a huge hurdle when I work with organizations that are trying to set up a program, because you want to serve all the patients, you want to serve regardless of where they live, regardless of what condition they have, what specialty they need a consult with. I hear from talking to strategy people all the time, and I say, okay, well, what specialties do you want to focus in on? And they say, well, we want to be able to do all specialties because we have doctors in every single department. But as Cole and Dr. Rasmussen pointed out, not all of those doctors are going to want to participate right away. Depending upon the different specialty, you're going to be dealing with different types of records, and that changes things in terms of what kinds of solutions you need for receiving those records, being able to review them. And also, you know, are you going to start domestically or internationally? What states are you going to offer this to start? And it can be really hard to narrow down the scope of your pilot program, but it's really, really helpful and really important, and kind of to take it in bite-sized pieces, because otherwise, if you bite off more than your legal department can chew, you might get shut down kind of before you start. So picking where to start is a huge one. The other one I would bring up, which is actually more of a industry hurdle, but it's still really important, is the issue of health equity and reimbursement. So currently today, reimbursement is changing pretty rapidly, especially after and through the pandemic. Increasingly, telehealth consults, remote consults are starting to be reimbursed by some insurance, but today a lot of remote second opinions are out of pocket. And, you know, if you really want to serve the patients who need, who can't afford to travel to you or take time off work, then you really, ultimately, the industry is going to have to start reimbursing for these kinds of remote services. And some, you know, panelists, feel free to jump in if you are reimbursing for part of remote second opinions. I've spoken to some people who are reimbursing for example, the video consult side of the remote second opinion. But today, an asynchronous case review, which is just a review of records by a doctor, really typically what we're hearing is not reimbursed. So health equity is a big one, and offering this program at all is a big step in the right direction, but getting that reimbursed for is the next one that they need to tackle as well.
Let's do a quick poll of the panelists just for a minute. Do any of you accept or request insurance reimbursement for any portion of second opinion, or is it purely out of pocket at this point?
I can start out, Les. So for the review of pathology and radiology materials to verify the patient's diagnosis, we will submit those to insurance for reimbursement, because there's a long history of doing that remotely, and insurance does does cover those services. But for the asynchronous written report from an oncologist to a patient, that is something that we either charge the patient for out of pocket or is covered by the employer through the MSK Direct program and the relationships that we have with employers in that program.
Other panelists, any comments on reimbursement?
And we haven't bothered to put in place the infrastructure to do any insurance billing, so we are, completely out of pocket for the patient, or through a benefit contractual structure that we put in place with payers or employers.
Yep, that's probably more the rule than the exception. Same with you, Nikki?
Yeah, we're similar. At this point, our remote second opinion program, which again primarily is asynchronous, is again a self-pay program.
Okay, cool. All right, so I want to ask a question that often isn't asked in the second opinion world, which is, how do you all measure your outcomes? How do you know if you're doing a good job? Other than, are you bringing in enough patients? Is there some kind of qualitative metric that you use to judge this, either from a patient point of view, or maybe even, as Dr. Rasmussen and other panelists pointed out, from a physician satisfaction point of view? Anything? Nikki, you want to start with that?
Yeah.
Sorry, go ahead, Dr. Rasmussen. You can start.
Yeah. So, we really revamped a legacy program that did not do well from a turnaround time standpoint, a physician satisfaction standpoint, a patient satisfaction standpoint, or a conversion to in-person care standpoint. So as we revamped our program, we really measured everything, and are measuring everything. So when we first launched the revamped program, we surveyed every physician after every consult for satisfaction and verbatim comments. We've pared that down now to twice a year to try to spare the physicians some burden of being over-surveyed to death. Every one of the patient interactions gets a survey, which is run through the usual Cleveland Clinic vendor. We take the patient experience extremely seriously at the Cleveland Clinic as a whole, me particularly. For those of you who know a little bit about me, know that my wife is the former chief experience officer at the Cleveland Clinic, and I've literally had to eat, sleep, and breathe experience now for about 10 years. And of course, it pays huge dividends in my own personal practice and in our program. And we average a net promoter score that hovers between about 65 and 70 on a monthly basis. We really try to make it a premier experience for the patients and deliver a superlative opinion to them. We also measure, obviously, the volume of consults that are moving through the program. Like everything else, you need to have a growing program. And what's most concern, obviously, to the Cleveland Clinic is the conversion to in-person care. So we're obviously measuring that. And then the Cleveland Clinic finance team also measures the downstream revenue and EBITDA that's associated with that downstream revenue. So there's a lot of different ways to look at the outcomes and benefits of the program. If you're a corporate customer standpoint, you're going to predominantly be interested in return on investment and cost savings. And, that's an extremely difficult thing to measure, to be honest with you. And what we start with in that regard with those discussions is an understanding that the best care is going to be the highest value care. And when you think about a second opinion from a payer standpoint, there are going to be three buckets that patients fall into. One is, we're going to agree with the local diagnosis and treatment recommendations, and there's going to be no change. Obviously, the benefit in that scenario is that the patient's going to have greater peace of mind moving forward with their local care and have confidence in their local healthcare system and their physicians in dealing with their problem. Then, of course, there's going to be times where we disagree with diagnosis and or treatment, and we're going to lower the cost of care locally. And obviously, that can be measured. Then there are going to be times when we disagree with local diagnosis and treatment recommendations, and we're going to increase the cost of care. And that's more problematic from the payer standpoint. Is what is the value of that? And in that situation, and you really kind of got to appeal to their humanity and report case studies around this. So I'll give you a great example of this. Is we've had quite a few opinions where patients reach out to us with heart failure and are told by their local cardiologists, and many of these are affiliated with major academic health centers, that situation's hopeless and you seek hospice or palliative care. And our heart failure cardiologists differ on this and believe these are good candidates for heart transplantation. So obviously that's an enormous difference between the cost of death, which is zero to the payer, and a chance at survival. And I don't really quite know how you value that, but clearly all of us in our heart know that's very, very high value that we're bringing forward, even though it's going to cost a payer or an employer more money. So it is very complex. I think it does require frequent and often explanations of what the benefits are that are being brought forward to all of the different stakeholders that are involved in a second opinion program.
Great, thanks. Let me just, for those of you in the audience who are not familiar with Net Promoter Score that Dr. Rasmussen mentioned, his score of 65 to 70 is in the stratosphere. Don't equate it to a 70% like a C. 70% is about as high as you could possibly get. So those are good grades, and we know from Cleveland Clinic in general that's something that you strive for there. Nick, you had a comment on that as well?
Yeah, I mean, I think again, if you ask about what metrics we're looking at, I think it's all the same thing that Dr. Rasmussen put out there. But again, being in a little bit not as mature program, some of the maybe patient experience, it's more anecdotal from what we get from them as well as from our providers. But we track the volumes, we're tracking the turnaround time, which is an important one to meet our metrics. Obviously in-person conversions with the downstream that comes from that. And again, some of the other things that we do look at, which again, just try to tell the story strategically, is where are these people coming from, right? So you can zero in if there's a specific country that you tend to have a physician that has a connection there, that they tend to bring in a lot of patients from that area because he's known to that. Then do you have multiple physicians that are still going into a country, and maybe that's an area that you can strategically work with your leadership to zero in on. I think some of your metrics can tell a story like that and help you kind of narrow in where you want to work on your program, whether that be in partnership with your international medicine program, your telehealth team, wherever that is. But I think sometimes your general metrics can also help tell a story for you.
Great, thanks. Cole, any further comments? I bet you're going to be pretty consistent with those.
Yeah, we're doing the same type of thing. There's a whole host of metrics that we are continually tracking, monitoring. The comment I can add here is that at different phases of development, the primary success metric has changed. So, as an example, when we were first figuring this out, first putting something into the market, we really cared about the understanding physicians' preferences and whether this was something they were willing to do, interested in continuing doing in the future. Now that we've established that, we know doctors are willing to do this, we don't need to track that as closely anymore. And our primary focus now is more on optimizing the patient experience, and aligned with Dr. Rasmussen's comments, how do we quantify the ROI for our employer partners who are paying for this service for their members?
Great. Claire, I want to reserve the start of the next question for you, but do you have a quick comment back on any anecdotes on measurements that you've seen in the field?
Totally. So your question was really, how do you know you're doing a good job? How do you know that this program's worth it? And that ties directly into the why that we were talking about. And given that health equity is a huge why for a lot of these institutions, really part of it is you need to be able to expand your reach. You need to be accessible to patients, and sort of any additional revenue from conversions really is sort of additional benefit to setting up a program. We have, especially with children's hospitals, I hear this all the time. They say we consider ourselves a safety net hospital. What that means is we need to be accessible for these patients who don't have other options. And so, you know, it's not so much a matter of metrics, although the financial side of things obviously matters. And when you reduce turnaround time, you make your program more efficient, then that makes it more of a more feasible financially, even if you're not making a ton of money. But really, it's we need to set this up because it aligns with our values as an organization, and then what you find is there are benefits financially, there are benefits for conversions. Patients are happy, physicians are happy, and that does improve your organization. But to a lot of these institutions, it's the actual financial side, and the metrics for saying how you're doing financially is way secondary to actually being able to serve the need of the patients who are coming to you.
Healthcare business is an interesting business, in that the top priority is not financial, and in most other businesses it is financial. So understand the struggle that we go through there, although all of us in the healthcare business know we have to pay our bills as well.
Of course.
So just quickly, I'd like to deal with this question of international. It comes up all the time, but Claire, the programs that you're seeing, do any of them deal with patients that are non-US patients? And has this changed during the pandemic? Are we staying away from international patients during the pandemic because they can't come to us if they want treatment? How's that working out?
So to start, historically, a lot of institutions, even if they didn't have a typical remote second opinion program, they had patients who lived in other countries who want to come for treatment to their institution. And I believe a lot of Yale, MSK, Cleveland Clinic is familiar with this. But what they're realizing now is what makes way more sense than just having a patient travel to the US for a treatment that they don't know if they qualify for, is to actually do a remote second opinion in advance of an in-person visit. So the ultimate result of this is often a procedure, participation in some kind of trial treatment, but to do a remote second opinion in advance to see if they actually are a good fit for the program can really be incredibly beneficial for international patients whose primary intention is to actually come to you for treatment. So we're seeing that a lot. In terms of whether things have changed during the pandemic, of course, the answer is yes. But again, I would say a lot of the clients that I work with who are opened up to this idea of remote consults say, okay, if I can serve a patient in another state, then I absolutely want to be able to serve patients internationally, and that's great. What I would say is you do run into barriers of language, of licensure in other countries. It's tricky enough in interstate licensure domestically, but when you run into other sorts of countries' regulations for healthcare management, it requires a lot of thought and research that goes into that. So I would say that as institutions are realizing they can do these remote consults, their intention is to be able to offer this internationally, whether the patient's planning to come in to the US for treatment or not. But again, it's bite-sized. You gotta pick your first avenues and then expand from there.
Great. So let me turn it back over to the panel. I guess there's a couple of things that we can unpack this international a little bit. So one is, do you do it? Two is, do you use it as a screening process? Maybe do you use second opinions as a screening process elsewhere as well, maybe for domestic patients? And then thirdly, is there a different way? How do you get past this licensure stuff that's going on, which is really hard because that keeping up with every single country that you want to serve, changing and very dynamic telehealth laws is virtually impossible today. So anybody want to, that's a hot potato question. Anybody want to jump on that one? No?
I'll jump in and start, and again say that when we started thinking about our remote second opinion program was right around the same time that we really started to strategically think about our international medicine program and expanding it. So I do feel like they kind of went hand in hand together. And honestly, here at Yale, most of our probably, I would say the majority of our volume right now in remote second opinion does come internationally. It's just the way that we have formulated our program because they work hand in hand together. And so, you know, again, during the pandemic, no, we did not have people traveling here as we did prior to the pandemic. But when you start adding together, we do use it very much like Claire laid out, that we do that second opinion written, and then from that, based on the determination of what the doctor is telling them, they may want to travel here again to seek our oncology care or seek a surgery from one of our physicians. And when that happens, then it's handing that over to our international medicine program. And then again, all of the details that come with that to have someone travel here, their medical visas, all of that is handled by the international medicine program. So I do feel like sometimes we are the start in our remote second opinion program to having that care happen here. And we do work hand in hand. And then the same thing with the telehealth team, which is where I am now. Again, we are looking at how we can do these video consults, again, whether it be across state lines or internationally, and how you handle that. And again, the difference between the actual practice of medicine, right, and giving a second opinion and all of the rules and legalities around that is really what you need to make sure that you are step in step with your legal team on, so that you set up the program the right way. Now, whether that be a provider to provider consult with the referring physician on the line with you and the patient in order to do these, or versus just a provider to patient interaction. Again, a lot of those things you need to vet through your legal teams in order to set it up a way that works for your particular academic medical center.
So that's, let me just point out, that's pretty common that we're seeing is the physician to physician, call that an exception, if you will, to licensure, to having your physicians licensed specifically in each of those locations. And I know there's other approaches that other institutions take as well, by ensuring that what they're providing is not necessarily a medical diagnosis, but perhaps education to the patient or advice that's not medical. Cole or Dr. Rasmussen, you want to comment on any of that you have at your company, at your institution?
I'm happy to chime in here, Les. The approach we take is involving the patient's local treating physician. As you mentioned, there's an exception to state licensure for physician to physician consultations, at least in the vast majority of states. So that's the approach we take to navigating the state licensure regulations. On the international front, we actually started with international. There's a long-standing program at Memorial Sloan Kettering to receive, for international patients to receive expert opinions from Memorial Sloan Kettering oncologists. When I joined Memorial Sloan Kettering 5 years ago, there was no way to do this domestically for patients outside of the states where we're comfortable, where we were comfortable operating. So my emphasis has been on making that service available domestically.
Good.
You know, we also offer this program globally, and you know, in terms of legality standpoint, you know, we have physicians in the UK and the Middle East and Canada. So frequently we'll try to match the patient to those experts from those parts of the country, those parts of the world. In addition, if we enter into a contractual relationship in any country, we'll have our legal team do deep dive on practice of medicine rules and regulations and telemedicine rules and regulations in those countries to make sure that we're practicing within the legal bounds there. But you know, just in case there's any health system attorneys on the call, you know, recognize your doctors are doing this every day, just informally. You know, these calls come in all of the time to physicians from around the world and around the country, and exactly what we're talking about here happens all the time. So you know, there's a lot of angst there. You know, take a deep breath and recognize the reality of what actually happens.
Great. We see that all the time, that there are informal networks that physicians have that are going to happen no matter what we do in the institutional side of a second opinion. So we do need to, I think, all take a deep breath on that one. Okay, so we're going to round up with one last question and then open it up for the audience. There are a few questions that have already come in from the audience, but if you do have questions as a member of the audience, please type it into the sidebar on your screen. So the last question that we have is, do any of you have spillover from your programs, your second opinion programs, for using it for transfer patients that are transferred perhaps from a non-specialty hospital that have, in the case of Cleveland Clinic, certainly cardio issues, or other than that? And do you then use this as a screening program for their existing records prior to their transfers to your hospital? And maybe we'll start with the Cleveland Clinic on this one.
We've got pretty robust capabilities for acquiring medical records and imaging and pathology specimens, et cetera, but for the most part, it's not utilized or leveraged by the enterprise as a whole. And no, we don't do anything as a screening process or on the transfer process. For the most part, we just accept everybody for the most part.
Good for you. Any other comments from panelists or similar?
The same thing. We don't use this as a screening process for transfers.
Okay, great. Okay. Well, now I'd like to open it up to the audience, and we'll take questions for a few minutes. Then I'm going to ask the panelists for any closing remarks or advice that they want to give generally about second opinions to help out those programs that are perhaps considering getting into this business. So questions from the audience. First question that came in was one, I'll call it a general question of how do you do this? Can doctors really do remote diagnosis without seeing a patient? And Claire and I have an interesting anecdote from that. When we first started in this business, now many years ago, we encountered that idea in the field, and we were told by several doctors that they weren't interested in remote second opinions because the doctor's role is to physically examine the patient, and without that, they can't form any opinion. Obviously, that's changed, and perhaps the pandemic has changed that a little bit. But panelists, any comments generally back on that one? We don't have to dig too deeply in that because obviously we're doing this. All three of you are doing this. But any comments back on that? Maybe it's an obstacle that we have in what used to be the practice of medicine and what we're doing today in telemedicine. Nikki, why don't you start off? I know. Sorry, you just did your millionth telemedicine visit I saw the other day online.
Yes, we did. So I think, again, probably if you take it in the lens of telehealth, right, we've probably overcome some of those barriers now. I think everyone realizes, whether it be a written remote second opinion or doing it over video, that it absolutely can be done. And clinically, there is a place for all of that. Yes, every type of clinical situation cannot be handled in the same manner every way, but there's absolutely an avenue for all of that. And I think it's just explaining that to your physicians, and you will have those, as we've said on this panel before, those who will engage with you and want to do this, and those who do not. And you just engage with those physicians who believe in it and want to do that work with you.
Great. Dr. Rasmussen, you had a comment on that as well?
Yeah, well, I mean, first off here, let's remember these are second opinions, right? So that means the patient has a diagnosis already. And as I'm sure Nikki and Cole can attest, you really don't want to run a program like this and accept a request from a patient for a symptom. As an example, abdominal pain is not a diagnosis, and invariably you're not going to make that patient happy because this is not a good modality to evaluate abdominal pain. But if you've got something like aortic stenosis and the question is, do I need my valve replaced and what is the best way to do it? I mean, this is the ideal thing for a program like this, when that evaluation really depends upon a review of a cardiologist's notes and their documentation of the patient's symptoms and trajectory of their symptoms. And, quite honestly, it all boils down to the imaging anyway. This kind of program is highly effective for those kinds of questions. I'll just give you a little anecdote here around telemedicine in general. One of the most senior physicians at the Cleveland Clinic just retired recently. He is a pulmonologist, world renowned. Like, the guy basically invented modern critical care. and how to ventilate patients in the ICU. And I remember when I first started talking about telemedicine 5-6 years ago, he expressed some concerns about, how do you listen to the lungs and things like this with telemedicine. And by the time he got around to retirement, I remember him sitting in a meeting with me, and he said, well, let's just be honest here, Peter, no one's listening to the lungs anymore anyway. And, that's just the reality. The physical exam, for the most part, is becoming kind of quaint and a little bit archaic in many ways, because modern medicine's practiced with data. It's going to be laboratory data. It's going to be imaging data. And that's what you really need to have in order to do the right thing with the patient. And fortunately, all that data now is digital and readily transportable through the EHR systems.
Great. So Cole, I'm going to lead you on this one, if you don't mind. But the question came in from the audience about experience with digital pathology. And they asked whether you require tissue blocks or do you accept digital slides? And I'll throw in that, and if you accept digital slides, do you prescribe the format for those digital slides? Since we know there's no standard format for them yet.
Yeah, great question. So we do have the ability to ingest digital pathology and to review digital pathology and render diagnoses on that. The challenge that we run into is digital pathology is just not widely used yet. So the vast majority of instances, we're actually retrieving the patient's tumor sample, either a slide of the tumor sample or a block, giving that over to our pathologist to look at under a microscope, and they're making a diagnosis that way.
Okay. So
oncology is actually unique in that diagnoses have always been made remotely without a physical exam of the patient.
And I'll just throw in on this here that my experience with the second opinions coming through for oncologic reasons, it's unbelievably crucial to get the pathology slides. And as I'm sure Cole's got many anecdotes around this. It's very common for our pathologists to disagree with the local pathologists. There's an example the other day, a patient from one of the southern states had a breast biopsy done. Her tissue was sent to a famous hospital in New England for interpretation, and then got a second opinion through our program, and our pathologist disagreed with that pathologist in New England, not Cole's program, by the way. And then, to really lend some credence to our opinion, 4 of our pathologists weighed in on that specimen. So it wasn't just like doc versus doc, it was 4 pathologists on our end reinterpreting that specimen. And what I found is our oncologists are really hesitant to give strong recommendations on a second opinion if our pathologists have not had a chance to review the specimen, right? Because they just simply don't know that those pathologists locally and how skilled they are. So I think if you're going to do a program like this, every effort needs to be made to actually get the tissue specimens. And I'm not a pathologist, I don't know this, but what I hear from our pathologists is that they actually prefer to get the tissue blocks because a third of the time our pathologists are doing additional stains on those specimens to further refine the diagnosis. So I think if you really want to do the best for the patient, you got to actually get those tissue blocks.
Yeah, I absolutely agree. An enormous portion of the value in the oncology space is that confirmation or change of the diagnosis through the review of pathology. And when you look at the statistics on how often the diagnosis is changed, it's actually quite scary.
Yeah, great. Well, thank you all. I'm going to turn it over to the panelists to give you their closing remarks now. We've got a few more questions that have been asked, and I'm going to ask those people just to indulge with us, and we'll try to get you answers post-program. But Nikki, if you wouldn't mind starting, any recommendations, any tips, any ideas that you want to provide to the audience for people that are either early stage in their second opinion programs or considering one?
Yeah, I guess my tip and advice would be is to make sure that you have the right leadership around the table from your academic medical center, your health system. Make sure that you have that support and that together you build that strategic vision and understand what that what you're considering is your return on investment and your value add to your academic medical center. And then once you have that in place, ensuring again that you can execute on it and also have that operational workflow put in place, because as we all know, without the operations behind it and perhaps the FTE and all of that that goes with it, your program's not going to be successful. So just ensuring you have all of that in place.
So buy-in is important. Yes, we've heard that before. Cole, words of wisdom from your side?
Yeah, just building off Nikki's comment. While that strategic vision is critical, it's equally as important to be not so fixated on that vision, that kind of perfect end state that you're working towards, that you're biting off more than you can chew, and you're preventing yourself from kind of starting small and taking the incremental steps that will inevitably get you to that vision. That's the big trap that I see a lot of individuals and teams and organizations falling into. They become fixated on that vision, and it prevents them from starting small and getting started.
Wow, that plays right into what Claire likes to talk about all the time. Dr. Rasmussen, any tips from your side?
Yeah, I mean, I agree with what the others have said. I think the other thing is to be clear on what your goals are. And also, you know, once you get into a program like this, there's a temptation to want to shift your goals. And only if we did this or only if we did that, we'd do X, Y, and Z. As we talked about, there are so many different laudable goals that you can have for a program like this. And I think it's a matter of really just defining what those are up front and sticking to that, because the way the program will be operationalized, the way the program is going to be priced, will all depend upon what your goals are. And try to avoid that temptation to go down the path of shifting goals over time.
And Claire, do you have any advice, short amounts of advice? I know you've got lots of advice for people.
Yeah, well, I mean, it's hard to follow all of that fantastic advice. What I would say is what everyone who's attending is already doing is there's no need to reinvent the wheel. One thing that's really cool about the healthcare marketplace that I've seen is it's very collaborative. Just the fact that we have our panelists here willing to get on for an hour and share their experiences and their advice on standing up these kinds of programs. You know, there are a lot of different approaches that different institutions are taking, a lot of different strategies, and a lot of that information's out there. And you know, your peers being willing to collaborate and work with you, and all of the advice we as a company pass on to our clients that we work with comes from the clients we already have, who are really the ones doing this boots on the ground. So yeah, and on top of that, I would just say one big thing is to think about what kind of staff you have who are going to be running this program, and to make sure you have champions at the physician level, but also at the administrative level when you try to set up this kinds of programs. But yeah, it's been really, really cool to listen to all of you and add a little bit of color from our other clients that we work with.
Great. Well, first, let me say thank you to all of you for participating in today's webinar. We really do appreciate it, and I'm sure the audience does as well. For those who have asked from the audience, this has been recorded, and we will provide video copies of this to anybody that needs it. I think to all the people that have signed up for it as we go past. Well, we've got to render the recording, as I understand it, and then we'll have it ready for you. And then third, before we're done, I think we'd be remiss without saying to the three professionals that are here from the healthcare industry, you all have really done a yeoman's job during the pandemic. Obviously, you do it all day long, but during the pandemic as well, I know you've all been called upon to do way more than your general role during this time, and we greatly appreciate it. So thank you. Thanks to everybody from the audience. We're going to put up a slide to share with you. So there's more coming up from Purview in the future. We're going to provide you with a document that was created by the advisory board called the maturity model. That'll be available to all of you. And then if you're interested, on the 31st of March, we'll be holding an online expert view demo, and I'm sure Claire will be involved in that one as your host. And then on the 22nd of April, we're going to be talking about health equity. And we have perhaps the world's most experienced speaker in health equity, Dr. Neka Setterstrom, who's going to talk to us about her views of how do you really do this? How do you achieve health equity, which, as we know, is a daunting task in today's world. Thank you all for attending today. Thanks again to the panelists, and we'll see you next time. Take care.
Thank you.